PCI, trying to rescue some coronary arteries or not to do any damage to them. Over the next 10 minutes, what I hope to do is really talk about my experience of modernizing various healthcare systems and having worked in various places across the world. So my experience really comes from, I've worked as a Royal College of Physician representative in West Africa. I worked with various groups of the West African College of Physicians to look at how they can develop their cardiac services. When we went first to West Africa, places like Ghana had only one cath lab. In Accra and other places didn't have any cath labs, so we looked at how we can develop it, and I hopefully can bring on to that as to why I think things like that could be modelled in Iraq. I've also helped work on establishing catheter lab and interventional services in Kenya, similarly in Bangladesh, to improve the Bangladeshi healthcare service and from a cardiac perspective establish MRI units. My particular focus has been women and heart disease, which is where I'm very passionate. And recently I've been working with Kuwait Healthcare. So I won't bore you, and I'm sure you all know this, but this is really revision for me, because without knowing what the actual problem is, it's very difficult to find where the solution can come from. So as you all know, Iraq benefits from a centralized free healthcare system, and this has been long established from the 1970s, which the people of Iraq have been able to benefit from. However, this is not completely free, because about 20% of the population pays out of pocket for expenditure of their healthcare. So this is very similar to places like India and the third world, where there is a lot of out-of-pocket expenditure, though there is a free healthcare. And that questions why people go and pay for healthcare, and we can come to that later on. Overall in Iraq, this is the data that I managed to get, that there are 229 hospitals, including 61 teaching hospitals in Iraq, which is a big number of hospitals. And actually, for comparative countries, where Iraq is doing very, very well. So what is the problem, and what's going on in Iraq? So if we look at the percentage GDP that Iraq spends on healthcare, and this is data that came from the WHO, that Iraq spends about 3.3% of its GDP for Iraqi healthcare. When we compare that to other countries that are next to us, so you can see Iraq is the light blue country, Iran and even Afghanistan seem to have a bigger healthcare expenditure. So we're not actually in Iraq spending that much money on our healthcare services. How does this compare to other countries? So I looked at some of the MENA countries like Bahrain. They are about 1.1% higher expenditure compared to Iraq. But remember, Bahrain has a much smaller population. If we look at Iran, they're spending kind of 2.1 times as much as Iraq is spending. And if you look at countries, even like Jordan, which is meant to have a slightly poorer healthcare service, they are still spending more money on their healthcare service. So one of the major problems in Iraq at the moment that I've managed to highlight is that the budget we have and the GDP expenditure is not as much as where we should be. How does that look in terms of the Iraq population? Well, we have about 31 million people living in Iraq. Our mean expected age of survival is around 69, around the age of 69. And if we compare that to other countries like Egypt, we're less than them. If we compare that to countries like Bahrain, again, we're less than them. So with our GDP, we also have a problem that our mean survival is also lower. What does that mean? What does that mean, and how does that compare? So overall, the 5-year mortality rate in Iraq is about 39 per 1,000 live births. So that's comparable to the rest of the Gulf states. But most interesting, and I think this is data for me to take away and to bring home, is that if we look at cardiac services, there is a very high rise in non-communicable diseases currently in Iraq. This is very similar to countries that are currently developing when we compare it to India, when we compare it to West Africa and Kenya and even East Africa. As infectious diseases have lessened, as the number of people dying from war have lessened, as there is more wealth coming into the country, the number of non-communicable diseases and people suffering from it has significantly increased. And this data suggests that you have about 44% of the population, and this is just recorded. There is many unrecorded data that's missing in Iraq. People have hypertension. A lot of people have are overweight and obese, and these are the challenges of any healthcare system. But impressively, beyond that, what we also have as a problem in Iraq is the number of physicians to our population. So when we look at Iraq, the number of doctors we have per 1,000 population is about 0.8. When we look at the nurses, is about 1.7. When we compare ourselves to other countries, we're doing much less than them. So we have a problem, and that problem is obviously something that's generated over a number of years to do with migration, to do with the brain depletion, unfortunately, of power that's Iraq and the war that has come through. But certainly that number hasn't improved, and it lags behind many of the Middle Eastern countries. So what does that all mean? Does that mean we have less money, we're spending less, we have less doctors? But how does that translate when it comes to heart disease? Well, when it comes to heart disease, actually coronary heart disease is the biggest killer of people in Iraq. It's overwhelmingly become the highest mortality cause of death in Iraq. If you look at the ranking from WHO, coronary heart disease sticks out as opposed to other conditions. And when we look at that and what it means, actually, so about 18.5, and if this was accurate data, so again, the data may not be as accurate as we'd like it to be, is about 18.5%. That's very significant, and actually that's very comparable to other developing countries and developed countries where there is major investment to reduce cardiac disease and cardiovascular death. So we have a big problem, and we have to kind of look at solutions. And again, this is just to reiterate that we're along the 19th ranked in Iraq in terms of the kind of the metrics of coronary heart disease being the major contributor to heart disease. And this is just showing kind of what's happened to mortality in Iraq over the last 10 years. And basically what I wanted to show that actually Iraq is comparable to other countries in terms of its mortality is here, the blue line. But actually what's happening is that now we're getting the surge of coronary heart disease, and other conditions will be increasing the mortality in Iraq. So it was very difficult, and I hope the doctor from Iraq can please furnish me with this data, is to find out actually how many cardiac interventions do we have, cardiac interventional centers do we have in Iraq, the breakdown of how many people in Iraq have heart attacks or heart failure. There was very limited data, and actually the data was very variable. So I don't want to quote it because I wasn't confident of what that data, and every place I looked, the data was very different. There isn't a clear breakdown of how many cardiology specialists are in Iraq. And actually, there's only 1 to 2 cardiac societies affiliated to a European society, so they don't seem to be quite independent. And so when we come to look at cardiac services and how we can improve them in Iraq, obviously the major issue would be to actually define where the problem is and to find whether we are catering for the population, and where do we go from there. So without the lack of data, with the lack of data, it'd be difficult to specify, but I'm hoping that I could bring some issues and some problem solutions. So obviously, the most important clear factor that's come through is that budget is a major issue in Iraq. We're not spending as much as we should be. We should be around the figures of probably between 6% of the GDP. If we compare ourselves to other kind of countries of similar wealth, ideally we want to be spending like Bahrain and Qatar, but we're not there. I can see that, but we should be aiming for at least 6% of the GDP. So we need to be spending twice as much on our healthcare in order to be able to deliver the healthcare that we want to. What Iraq unfortunately lacks on top of it is an infrastructure that's been demolished over a number of years. This hasn't happened overnight. This has been many generations, unfortunately, wars, and also the lack of investment in the infrastructure that has led to this. So there is no continuity of infrastructure. And though this is a nationalized or a centralized health system, the infrastructure in Baghdad is very different to the infrastructure in the south of Iraq and in the north of Iraq. And that creates a big problem when you're trying to resolve how you can solve a problem or how you should be investing money into the problem. The access to primary healthcare and preventative strategies in Iraq is very limited. So as I mentioned, non-communicable diseases are one of the biggest killers of people in Iraq. If we're having 20% of our population die from coronary heart disease, we assume similar numbers of people will have heart failure, We know that at least 70% of our population is obese. We know about 80% of the population smokes. And there is very little strategies in the primary healthcare setting for kind of preventative therapy, which is very, very important. When we worked in West Africa, one of the things that we very much focused on was about how to bring in preventative strategies. One of the biggest killers in West Africa is cardiovascular disease, but it tended to be stroke and it tended to be hypertension, and it mainly was hypertension in male. And actually just setting up very primary clinics in remote areas that can measure blood pressure, so nurses measuring blood pressure and highlighting which patients need therapy, that was one of the ways they actually managed to reduce hypertension by 20% in the north states of Ghana. So very small strategies, but actually very, very effective. In addition to that, Iraq, access to tertiary care is limited as well. I mean, from a heart attack point of view, there is no primary PCI at the moment in Iraq. There is very little data to say how many patients are transferred via primary PCI route. I assume the door-to-balloon time and all the factors that we use to measure our outcomes is also missing. There was no data available on this sounds very negative that I'm bringing through. There is none and none, but it's not to say none, it's just to say these are the things that we need to focus on when we want to improve a healthcare system. There was no centralized bank to look at how many primary PCIs had been finished in Iraq, what was the success rate, what was the complication rate. And these are transparent data that should be visible for any healthcare system that wants to develop itself. In addition to this, and I know this from having spoken to people in Iraq, I myself, I'm affiliated to the IHH hospital in Karbala through the LFT charity, and I do work on improving their cardiac healthcare system over there in that hospital, is that there is minimized education and training. So training isn't centralized to geographies where you kind of say, I've got this population, I need to make sure that I have 100 cardiologists between now and 5 years' time. That doesn't seem to be visible, or doesn't seem to be in the target of the healthcare system that needs to be delivered. Certainly, there is a lack of investment in digital technology, but this is a problem that comes later on when you develop a healthcare system. But to have the basis foundation of it is very key and important, because it's much harder to develop later. But by digitalizing and having digital technology, it means you can deliver remote education, you can deliver remote clinics, you can deliver everything in a remote way, as we are currently doing. And therefore, that is actually very important to any healthcare system. I mentioned the sustainability and comprehensive and transparent system that it's missing, and hopefully that's something that can come through very quickly if it was to be developed. And then I did talk about there is some discrepancy in the nationalized healthcare system. There is a very overburdened healthcare facility or system in southern parts of Iraq, where in the centralized part of Iraq, because there is more money, there is more footsteps on doctors, there is more private healthcare, it tends to be less pressurized. So if we're talking about this being a nationalized healthcare system, there seems to be a lot of discrepancy that would need to be, the gaps need to be closed for this to deliver better. Right, so how do we move to solutions? And I guess I kind of pinpointed some things, but I did want to go into a bit more detail, and hopefully I can discuss this over the next few minutes without boring everybody. But the key question about any healthcare system is, what is the best healthcare model you can have for that country? We all assume that because Iraq has a free healthcare system, it should remain that way. But actually, that may not be the case. And actually, if one did a deep analysis, is utilizing kind of tax-based healthcare system. So this is something that the NHS uses. So it's not free healthcare, it's tax deductible. Social healthcare system, which runs in places like Germany, and privatized healthcare system may be a better model. And if I was to design this, I would probably say a combination of a social healthcare system as well as a privatized healthcare system would be better fit for a country like Iraq, because of the healthcare demands it needs, because of the population it has, and as it is already 20% of the population pay out of pocket for a private healthcare system. And that way you can develop a healthcare system better than rely on a demolished healthcare system that doesn't actually deliver. In terms of cardiovascular health, if cardiovascular health is the biggest cause of biggest cause of mortality, biggest cause of morbidity in Iraq, the most important factor is that there has to be proportional expenditure for the healthcare service. I.e., if 20% of people are dying from this disease, there should be an equal amount of costs going to it rather than it going to immunization programs or etc. etc. Of course, those things have to be delivered, but if you do not invest in something to expand it or make it better, then of course it would be lagging forever. And it's not just for about heart disease. I think we forget that non-communicable disease are very, very key and important, and there should be an investment and political commitment in preventing these diseases. Smoking campaigns, the government has signed legislation to say that they will be kind of delegating money into smoking campaigns. Now that hasn't delivered. Similarly, there is data from WHO to say that there has been political commitment towards running hypertension clinics and also diabetic screening, and that hasn't delivered. So it's not just about the investment, there needs to be also a political commitment towards all of these strategies. I am a big believer of training and education. When we went to West Africa, when we went to Bangladesh, we looked at simple models. Is how many people do you need per population of healthcare area to deliver the service? And there's no point supplying 100 cardiologists to a particular speciality or to a particular area when you only need 5. So I think you've got to match your demands and needs in order to be able to deliver the service you want to deliver. And I think Iraq needs to look on the model to keep its doctors in, to bring doctors with expertise who are willing to come and do the training and the education. And certainly this is something the countries of the Gulf benefit humongously from. If you look at like places like Kuwait, they all have the, collaboration programs with the big hospitals across the UK, US, and Germany. And what they do, they maintain their trainees in the country. They bring the best caliber physicians from outside to train them on a regular basis. And that means also that you train your doctors without having to take them out of the country, but also with the benefit of the best training program they can get into. And I think that's very, very important to maintaining the supply of doctors in your country, and not to have this movement which we have, which is lots of doctors unfortunately finish medical school and leave Iraq because they don't think they can get the training they need to get. Unfortunately, as I said this before, Iraq lacks a primary PCI pathway, and this is a very long battle because it's not just dependent on the hospital.
3 minutes, Dr.
Thank you. I'll try to finish. It's not dependent on the hospital. It's not dependent on just the physicians. It's simple things like traffic. When we went out to Bangladesh, we realized very quickly that Bangladesh and Dhaka cannot have a primary PCI pathway. And the reason is that believe it or not, the trafficking in Dhaka is ridiculous. It will take 4 hours to travel maybe 1 mile. So unfortunately, for that reason, because of the roads and the infrastructure of the roads, you wouldn't be able to deliver a primary PCI pathway. And therefore, these are things that you need to look at when you develop these things. Now, I know Iraq is overpopulated, and I know that, not overpopulated, sorry, over-trafficked, and I know Baghdad certainly is in certain regions. But when you come to deliver a primary PCI pathway, is to look at where you would have the best roads, where you would have the best infrastructure, where ambulance can drive out to these places and deliver the patients in that infrastructure. So it's not just as simple as let's set up a primary PCI pathway. There has to be a lot into it, and I'm happy to go into that at a different point. Finally, I just want to talk about, there is this program, which is the Iraq Public Sector Modernization. It actually exists. There is a huge amount of documentation around this, but unfortunately, it's not being utilized in Iraq. And it's fantastic because it has very much of what we've spoken about. But there needs to be an appropriate utilization of the guidance and the kind of the mandate that has been put in, and also to have long-term planning and goals for any healthcare service. What happens in countries like Iraq and West Africa and other places is that they look at the budget at 3.3 GDP, and the next year they would increase it to 4.1 just to satisfy the politicians and the people around them. That doesn't work. What one needs to do is to have long-term planning and goals of a health service. What do you want to have in 10 years, 5 years time, what do you want to have in 10 years time, and where do you want to be in 15 years time. And only on those bases can one actually look at modeling and look at strategies to kind of defeat certain diseases or reduce the burden to the economy of these certain diseases. And I think I probably have reached my final slide to thank you all for listening to me for the last 10 minutes. I hope I haven't bored anyone. And I'm really happy that we have someone from Iraq who may be able to furnish us with where we can find some data, because I struggle to find